Hi, it's Dr. Centeno, and sorry I'm running just a little bit late. Had a problem with one of the cameras on my desktop, so I had to switch to my laptop. So let's see. Today we're going to talk about PRP use in the spine and what kind of research exists with regard to PRP use in the spine. And we'll go from there. Again, as usual, I'll give a short presentation and then we'll go from there to questions. I see we got one or two questions coming in, and hopefully we'll get more as time goes on. So let me switch to sharing my screen here. Okay, looks like that worked. And then we'll go and start this again. Today we're going to talk about PRP use in the spine and what kind of research is out there. So the title for today is there research behind using platelet-rich plasma or PRP in the spine? And I've been doing PRP and mesenchymal stem cells in the spine for a very long time. The first case I did was 2005. So that's almost 2 decades ago. And during that time, kind of figured out what works, what doesn't work. Now, what's been really exciting is the last 3 or 4 years, we're starting to see more research get published in this space supporting the use of PRP in the spine. Now we have dozens of randomized controlled trials on PRP use in the knee and lots in the elbow, and we've even got some in the hip, etc. But I've been surprised by the amount published in the spine of late. So let's review to better understand today's topic. The platelets in your blood have growth factors. Hold on a quick second. I've got to adjust this presentation a little bit. Had some timings in there. Okay. So the platelets in your blood have growth factors that can act a little bit like an espresso shot for your body's local repair cells, meaning that if we use a construction site metaphor, if I'm the head of a construction company and I've got a bunch of construction workers that are building a building, and I go and buy everyone quad espresso shots at Starbucks, I'll get more work done that day. And that's what PRP is like. It acts like an espresso shot for the cells on the ground that are involved in the repair response. And one way to improve healing using platelets is to use a centrifuge to create something called platelet-rich plasma. And these platelets work by releasing growth factors and exosomes over about a week period. And consequently, by timing that growth factor release, they can orchestrate a repair response. So what high-level research exists in the spine that you can use PRP? And what I mean by higher-level research is a randomized controlled trial. I just did this last week. There was, as you can see, a number of studies available. Each little square there represents a different randomized controlled trial. Off to the left there, you've got the types of structures treated, the disc up top, the nerve or lumbar radiculopathy, meaning an irritated spinal nerve, the facet joint, and then SI joint. There was only one negative trial that used PRP. That's that BISE study there. But it only really measured response at 6 weeks. And I'll talk about that here in a second. So the first type of study out there as of just last week was where they injected the disc. Now, initially I thought there were two studies here, but regrettably the second study didn't use PRP. I blogged about that, so if you're interested in reading more about that, go to my blog. But this LUTS study did use PRP, and that's injecting directly into the disc itself. Now, this is mostly effective for patients with discogenic pain. And that's not everyone. In fact, that's probably the minority of patients walking around with low back pain. Discogenic pain is a very specific type of pain, usually in younger patients that are younger than 50 or so. And any type of sitting for more than 5 to 15 minutes will cause severe back pain. And these patients usually have a little tear in the disc that can be seen on MRI. And again, they're very sitting intolerant. And so this was a randomized controlled trial. There's been multiple years of update published on this trial, showed excellent results of PRP versus no PRP injection in the disc. Then we go to lumbar radiculopathy, and this is where we've got an irritated spinal nerve. So now the disc itself isn't really causing pain, but there's something irritating the disc, and that's causing nerve pain down a leg, let's say. So this would be what we call sciatica or sciatic-like pain. And there were 4 studies published, and this is where they used platelet-rich plasma epidural or PRP epidural. And 3 of those that had a longer term follow-up. So this one, and this one all were positive. Now this one compared PRP against steroid, but it only followed these patients up for 6 weeks. And that's not long enough for PRP. Normally you've got to get to 2 or 3 months before they turn the corner. So it concluded that PRP at 6 weeks didn't work any better than steroid, but regrettably, it just didn't look long enough. As you can see, these other follow-ups on these other studies are 6 months, and it usually takes about 2 months for someone to turn the corner there. Then we've got lumbar facet pain. And there were 2 studies where PRP was injected into arthritic or injured facet joints. Again, both showing excellent results. And again, just so that to remind you, we've got the disc in the front and the facet joint in the back. The facet joint's about the size of a finger joint. And that joint was injected here after it was determined that joint was causing pain. So facet joint pain can be things like pain straightening up in the low back, or many times patients will say they can go bend forward and pick something up from the floor. It doesn't bother them so much, but coming back up bothers them more. Or being very stiff in the back in the morning and having a hard time straightening up. Those are all signs of facet pain or pain coming from the facet joint. And then finally, there were 2 studies showing PRP use in the spine and SI joint or sacroiliac joint. And the SI joint is on either side of the tailbone there. And again, both of these were positive studies. So pretty good to see all of that. Now, I do want to remind everyone that we have an open study here at Regenexx, and that's a functional spinal unit approach. So really what we're seeing in the literature right now is, people who are just starting to figure out how to use PRP in the spine. They're trying to use it like they did injecting a steroid. And so they're just sort of substituting PRP for the steroid. They're just putting it in one spot because that's what they're used to doing. But we've seen much better results when you actually use PRP, platelet lysate, platelet poor plasma for the whole functional spinal unit. So you inject the facet joints around the nerve, into the ligaments, into the atrophied muscles. And again, that's called the functional spinal unit approach. We call that procedure the Regenexx DDD procedure. And we have a randomized controlled trial ongoing right now. So if you get accepted into that trial, it's free to you. And there's a crossover. And the crossover means that if you happen to get in the placebo group, after 2 treatments, you can cross over to the real treatment. So either way, you're going to get treated, and it's no cost. At least no cost when it comes to the actual procedure itself. And we've seen about an 80% success rate through the years. And now we're testing this using a more rigorous randomized controlled trial. And these are the inclusion criteria. So you have to be a lumbar fusion candidate. You can't have had a prior fusion. You have to have lumbar degenerative disc disease. You have to have failed physical therapy. Again, no prior back surgeries at all. Low back pain is the main problem, and you can't receive any other care for the duration of the study, which could last up to a year. So in summary, there's mounting evidence that PRP injections can help patients with chronic spinal pain. We have an ongoing randomized controlled trial using that functional spinal unit approach. That trial is free of charge, meaning that you won't get charged for the care itself. And you'll be randomized either into a treatment group or into a placebo or sham group. If you happen to get in the sham group, we will tell you at the crossover point, and then you can get the real care, again, free of charge. So I think that's all we have for today. Let me go ahead and get back and try to answer some questions here. Okay, so questions. Andy, given that alar transverse ligaments are the strongest ligaments in the body, is this why 1 out of 15 EDS patients have CCI instead of a higher percentage? I mean, could be, sure. Again, just realize that not everyone who shows instability in the upper cervical spine will even show symptoms. So when you say CCI, I'm assuming you mean symptomatic CCI. Duct P, if you use higher concentrated PRP, does that mean you have to inject a lesser amount onto a ligament to get healing response? Not really a lesser amount. So it's still the same amount. The amount of PRP that's used is the amount necessary to cover the ligament or other structure, whatever it is we're treating. Duct P, with the advancement of biologics, do you think we'll get to a point where a surgeon just opens the craniocervical area and pours biologics onto the CCI ligaments in surgery? Well, no, probably not. I think that would be a really dumb thing to do because you'd be damaging a lot of structures in order to place the biologics. Meaning one of the things you have to understand that all spine surgery is damage in order to accomplish a goal. So it's incredibly important that patients understand that there's a certain amount of damage that'll be done just getting the stuff where it needs to go. So you wouldn't want to do any damage getting the stuff where it needs to go. That would be through injection. That would be the least damaging way to get it there. So if all you're trying to do is to get something to a spot, surgery would not be a great way to get to that spot. John, do you have any EDS patients successfully treated PASL during its beginning days that are still doing well, don't need touch-up treatment? Yes, I believe we do. In general, once patients get to a steady state, we generally don't use much in the way of touch-up treatment, or at least we haven't to date. John, should Florinef usage be discontinued prior to prolotherapy, PRP, or BMC? Yeah, anything that contains corticosteroids is not something that would be a great fit. Now, if we look at when you would do that, it'd be better if you used it after the acute inflammatory response were over than during that acute inflammatory response. It's been advanced by Amber Schmidt. Hi, do you find scalenes, SCM, suboccipital, upper trap, rotator muscles become extremely tight in compensation for loose ligaments? I have tightness in all the areas, including upper trap and rotator cuff. Feel that they are compensating, and they are worse when my occiput goes out. Yeah, certainly the upper traps, the scalenes, the SCMs, and the suboccipital muscles can certainly get very, very tight, including the upper traps. So yes, that's a pretty common pattern. John, have you ever turned an EDS patient away for a PSL procedure, couldn't find any evidence of their symptoms being caused by CCI? Lots. Yeah, I mean, we see lots and lots of patients who we either turn away or basically say, listen, I think there's a low likelihood that we're going to help. We don't know that your symptoms are coming from what we're seeing, and you need to look at the risk benefit of something like this and decide what you want to do. I can't rule out that your symptoms aren't being caused by the upper cervical spine, but I think there's a low likelihood of that being the case. So yeah, we do that all the time. Centeno-Schultz Clinic has been advanced by Sherry Scott. Is PRP something that is universal, meaning would I get the same thing and same procedure from anyone offering the procedure or not? No, regrettably, it's not universal. Big differences in PRP between clinics based on the kit they use, how they prepare it, etc. So regrettably, it's not universal. I can't even tell you that you'll get the same dose from clinic to clinic. That's one of the things that we've done at Regenexx is we've standardized all that stuff. So if you're at a Regenexx clinic, you can be certain that you're going to get high quality PRP from place to place to place. But once you go outside of that system, you can find either high quality PRP or junk. And it's hard for patients to tell the difference. How can I reduce my central sensitization for my PICL? I don't know that you can. There are certain drugs that could help, like Lyrica. Lyrica is one that may reduce central sensitization symptoms, but in general, that's not something that works real well outside of just medication-based treatment. So certainly trying something like Lyrica would be a reasonable first step. Nisa, when is it warranted to use PRP as opposed to the port plasma with regards to a spinal injury? Yeah, so PRP is used in things like the facet joints. We talked about that. PRP is also used in other structures can be used in ligaments, depending on the ligament that we're trying to treat. Platelet pore plasma tends to work best in atrophied or otherwise damaged muscles. Krishana, is bulging disc itself a problem? Can it progress to herniated disc as you age? Many orthopedic doctors say it's normal and seen on MRI in normal population. No, by itself, it's not a problem. It needs to be correlated with the patient's symptoms and exam. So, so what they're saying is accurate, but it takes a good 15, 20 minutes to perform a physical exam on someone, to review their imaging yourself, meaning that the doctor is looking at the imaging with you, not reading a report, and decide whether or not the complaints match the exam, which matches the picture. So that's the process of trying to see whether or not those bulging discs are meaningful for that patient or meaningless for that patient. Nisa, when is it warranted to use platelet-rich plasma as opposed to got all that. It's been advanced by DB. I read your Platelet Raisins blog. How would someone doing this work make that kind of mistake in the PRP? Isn't there some kind of regulatory body making sure the procedures being done are correct? No, there's no regulatory body. That's why you got to stick with Regenexx physicians because we heavily educate our guys. They do the same things on patients, use the same products on patients. And if someone's making that kind of mistake, they'll get kicked off the network or warned. Outside of that, it's the Wild West, baby. It's just simply what it is. There isn't anyone who's monitoring that. So, for example, in that particular case, just that everyone understands what we're talking about, there was a study that purported to use PRP, but instead they were using platelet raisins. And what I mean by that is that the study author, for whatever reason, decided that he was fond of this plasma concentrator. And the plasma concentrator, you would put poor plasma into it, and it would literally dehydrate and pull a ton of water out of that. So you put in like 30 cc's, and you got like 4 cc's of syrup, literally syrup out, plasma syrup. And the concept was that it was going to increase the good proteins, also the bad ones, within plasma. And he combined that with PRP and injected that into the disc. Now, once he combined it with PRP, just basic chemistry and physics will tell you that that concentrate, that syrup, pulled all the water out of the platelets. So by pulling all the water out of the platelets, platelet raisins were created that were probably non-functional. So he no longer injected PRP. Now, why did the guy not realize that, since that's basic chemistry that he should have learned? It's a good question. Maybe he didn't pay attention in class. Maybe he didn't think about it. You know, there was no one, the company that makes the platelet concentrator doesn't say much about it because they're smart. They know that if they make any claims about it, it won't just be a device that's easy to get approved. It'll become, you know, something a device that makes a drug that's hard to get approved. So the bottom line is there is no regulatory body. There is nobody watching outside of Regenexx. So that's the reality. John Hall, is platelet lysate prolotherapy mixed better for lax ligaments compared to PRP alone? Do you mix 12.5% dextrose solution with platelet lysate solution? You inject them separately. They're mixed, and it's a good question. Is it better than PRP? I don't think it's probably better than PRP, but it's got different properties. So, for example, a dextrose solution, when it's injected, one of the nice parts about that is that it's neurolytic. So if there are free nerve endings in a ligament, let's say, and the ligament itself has become painful, the prolotherapy solution can dissolve those. But we want those platelet growth factors as well. So the only way to combine those two is put a platelet lysate together with a prolotherapy solution. Now, on the other side of that equation, you might be in a situation where you don't want to get that 12.5% dextrose solution anywhere near a nerve, in which case, or close to an artery, in which case you can switch to using platelet-rich plasma and get a similar result, but you don't have that neurolytic effect. Strange. How soon can we go through an ultrasound MRI venogram after PICL? The restriction to undergo such tests after our neck injections. No real restrictions of which I'm aware. Venogram maybe, because that's going to involve using contrast, which could affect the cells. But when it comes to a regular ultrasound, regular MRI, I don't think it would affect much. NISA, when using regenerative medicine, are the capsular ligaments also injected? How do we know which ligaments need to be injected? So NISA, I would invite you to spend some time with and to look at the CCI subtype videos that I have. That's how we know what ligaments need to be injected. And the answer is, when we are injecting the facet joints, we often inject the posterior capsular ligaments as well. But be careful. When someone tells you they're injecting the capsular ligaments, it's usually because they don't have the skill set to inject the joint proper. And they're not even injecting the capsular ligaments. They're just sort of putting the needle somewhere in the vicinity of where the facet joint lives. So as soon as I hear a provider telling me they're injecting the capsular ligaments, I know there's a 95% chance that what I'm being told means the provider is B team or C team and not A team, as far as being able to have the skill set to put this stuff where it needs to go. NISA, can you continue using a low-dose naltrexone after having a PICL? If so, how long after? Yeah, you can continue using it both before and after. The problem with using it before is it increases your personal risk with anesthesia. And what happens, it generally tends to turn that patient into what we call a tightrope anesthesia patient. That is, it takes tremendous amounts of medications to keep the person asleep, and they can be easily overdosed as a result, and then stop breathing. Then we have to stop the procedure, oxygenate the patient, let it wear off a little bit, and the whole thing repeats. So the things that tend to do that are low-dose naltrexone, narcotics, someone who's on a ton of medications prior to the procedure, someone who does a lot of THC and or CBD. Those are things that tend to cause that tightrope patient. Now, when it comes to low-dose naltrexone, you can get right back on it. There's not a problem there. It's just using it before the procedure tends to increase the risk, the personal risk for the patient for anesthesia. Andy, do you think the posterior ligaments, capsules, nuchal, BAM, or the muscles play a role in heavy head feeling? Probably the muscles is what you're feeling there, meaning if you've got a lot of ligamentous instability, you tend to get muscle spasm, at least in the short run. But usually muscular atrophy is what's causing the head heavy feeling. Sarah Morris Morano, hi, I'm 10 days out from my first PICL in mid-July. I feel like I've returned to baseline. There are a few days post-procedure. I felt like more stability and awareness of small triggers that have big symptoms tied with them. I'm now able to sense those small triggers and feel most okay when I'm laying on the floor with a rolled towel under my neck. Does it tell you anything? And maybe doing too much activity-wise? No, that sounds about right. I don't know exactly what you're doing activity-wise, but sounds like you got a little bit of a honeymoon effect, which is good. And your body is telling you that it wants curve. So I think it is just fine to lay on the floor, increase or use the rolled up towel underneath your neck to push a curve into the spine at this point. Now, obviously, if it starts to feel not good, then back away. But I would go with it if that's what's happening. But I don't know exactly which activities you're doing and not doing. Calazonia, got 2 sessions of PRP done this summer, feeling good about it. Great. And Andy, I think we've answered this one a whole bunch of times here. So they're about the same width, but again, I don't think I'd be so concerned about the facet capsules. I don't think they're major stabilizers of the upper cervical spine relative to the big ligaments and the big muscles. John, what doctors besides you and Dr. Schultz at your clinic can perform the PICL procedure? The only other doctor who does a few of them right now is Dr. Pitts, but I probably do these days about 70% of them. Dr. Schultz probably does about 25% of them, and Dr. Pitts maybe about 5% of them. John, have you ever had an EDS patient with posterior upper cervical instability do well with posterior PRP alone? We have, yes. Submitted advance by Harry Winston. Is the digital subtraction piece of equipment you've mentioned necessary for all spinal injections or only for neck injections? Really, Harry, only for neck injections, only for upper neck injections. You wouldn't even need it if you were going C2, 3, and below. John, any DMX reports you've reviewed of hypermobility patients that have absolutely no overhang or extremely minimal 1 millimeter? Yeah, John, I think you bring up an excellent point, and that is that hypermobility patients tend to be more likely to have overhang. And then the question always becomes in that patient, how certain are we that they're getting upper cervical symptoms related to that overhang? So for example, let's sort of break this down. Let's say I've got a hypermobility patient. I do an exam. It's clean. There's nothing that looks like it relates to the upper cervical spine. And that hypermobility patient just has some autonomic symptoms, no headache or dizziness and balance that might relate to the upper cervical spine. Then the message that's delivered is I don't know with high confidence that what I'm seeing, i.e. the DMX overhang at C1, C2, is causing your symptoms. And that's an important distinction there. Nisa, thank you for your thoughtful responses. Certainly, Nisa. Mark, are there any reasons not to do red light therapy after a PRP or stem cell treatment? None that I see. Ulysses, I know you don't recommend all your Regenexx Clinic not to do the upper facet joints, but can they at least safely treat the nugal ligaments like the easy ligaments? Yes, Ulysses. So for the standard posterior ligaments, that's usually not a problem. It's just when we get into the upper neck facet joints and the deeper injections. Follow-up activities I'm doing are primarily putting light things in small boxes, moving, nothing too heavy, not even lifting the boxes, occasionally short walks. Yeah, that sounds reasonable to me, but obviously listen to your body with all of that. Finn, is there data on the collagen deposition dynamics over time following PRP injection into the ligaments? Similarly, what are the functional strength dynamics? Yeah, we have most of the data on platelet-rich plasma when it comes to fibrous tissue healing is on tendons, and it's positive for improving the collagen matrix. There's actually one live study in the Achilles tendon that was done with a biopsy in real patients. Similar things for ligaments, but most of the data is going to come from tendon healing. Nisa, last question. Do you recommend patients doing another DMX after the PICL? When would you suggest this? Yeah, only if we're in that situation where we really don't know what's going on, meaning that I think we always have to balance the exposure of patient to radiation with the with wanting to get information. So if we absolutely need information, then that's fine. We can certainly get that. And that would be a situation where the patient says, you know what, I just don't feel any better. And we're trying to see whether we did anything with the first treatment. But we don't do it on every patient because we are always concerned about exposing the patient to radiation without a reason to. John, what physical exams do you specifically do in hypermobility patients to rule hypermobility of the upper neck versus actual instability in the upper neck? Yeah, John, I think you're not understanding the general concept that I'm relaying here. Basically, the focus of the exam is trying to determine if the upper neck is causing symptoms. And what I mean by that is, for instance, are the upper cervical facet joints tender? Does neurologic exam focus in on the upper cervical spine? Those sorts of things. So it's not enough just to have instability. You have to have instability causing symptoms. Mark, Dr. Centeno, when you eventually retire, do you have plans to have some of the doctors, Centeno-Schultz, begin to do more PICL treatments? I'm asking, thinking of Dr. Pitts, Dr. Merkel, or any others. Yeah, so that's the goal. I think what we'll do at that juncture is we'll probably train a number of people around the country or internationally how to do this. I think at that point, we'll have everything published that we need to, and we'll have obviously many, many years of experience to relay. So yes, that is the game plan, as I've talked about in other lives. John, for upper cervical facet injections, what doctor in your clinic do them besides yourself? I was thinking that may play a role in how long patients have to wait. Myself and Dr. Schultz do the largest number of those. Then again, Dr. Pitts in a similar fashion, and then Dr. Merkel does some of those. So if we're talking about just getting upper cervical facet injections and not PICL, that's how that goes. Finn, do the PRP injections of the facets affect the cartilage? Yeah, it's a good question, Finn. Based on what we know about PRP injections and other joints like the knee, the answer is probably yes, but I don't think anyone's studied that in facets. Finn, how many weeks post PRP injection is the majority of the healing concluded. Depends on what we're talking about, but if we're talking about ligaments in a young person, probably 3 months to 2 to 3 months. If we're talking about ligaments in an older person, then we can go all the way up to 6 to 9 months. And Magda, hi, Dr. Centeno, what's your opinion on using EMTT therapy to enhance healing post-PRP on SI joints, lumbar spine? Not against it at all. I don't think we know that it will do anything to enhance healing post-PRP, but I'm not against it at all. Okay, guys, any other questions about PRP use in the spine here or anything else for that matter? Sarah, how does a recent PICL patient get cleared to start curve restoration PT? Yeah, we wouldn't want to do that until you were fully healed from the PICL. So that approval might come at 3 or 4 months after you report things like the towel, lying face up in a towel really seems to help. Putting a curve back in feels good, that kind of stuff. Mark, what do you recommend for maximum Lyrica daily dosage and duration? Yeah, it's a good question. Lyrica can be started as little as 50 milligrams twice a day. You can go up to about 150 milligrams twice a day or 300 milligrams a day. You can even go a little higher if necessary, but that's sort of the dosing, and that's really patient specific. So the goal would be to start at a lower dose, see if that works. If not, go to a higher dose. John, I'm guessing for Dr. Merkel, for upper set injections, I can get him much earlier. Have you given him a green light to do these? Yeah, John, again, the focus here is our clinic is specific to getting you in with a doctor who knows who sees this kind of problem all day, every day. So when it comes to upper cervical issues, there are really only 2 doctors in our clinic that see this stuff all day, every day. That's myself. I do about 70% of it. And Dr. Schultz, again, does about 5% or 25% of it. So the goal is not mechanistically, can someone do a facet injection, but how do you manage this patient population? It's quite different than other patients or other spine patients that we see. Magda, how long post-PRP one could try the EMTT therapy? I don't have any specific guidelines for that. Sarah, when you say putting a towel really seems to help with regards to time frame of starting curve restoration, are we looking for longer-term positive impacts of the role of towel? Not necessarily, but I think you need to get to that 3 or 4 month mark before I would approve you really getting any more aggressive with curve restoration, because we want to avoid putting a lot of pressure on that spot, meaning the hypercervical spine. Any other questions that anybody has for today's Facebook Live? Again, just to review, we were talking today about PRP use in the spine and some of the research that's out there. Sure, happy to help. Okay, guys, I will be here this Friday, and so look forward to your questions and another topic on this Friday. Thanks so much for watching. Everyone have a great week. And again, I'll be here back on Friday. Thank you.